Hello, dear friends of Dental XP. My name is Manuel de la Rosa. I am a periodontist from Mexico, and today I'm really happy to be with my sister, Marcela de la Rosa, who is an orthodontist, and we work together in a team clinic in Mexico.
Hello, I'm Marcela de la Rosa. I'm an orthodontist, part of this team. I have an orthodontic practice where I treat adolescents and adults. Just as posed at the EAO a couple of years ago, we have seen in the last years that the adult population of patients have significantly increased.
So today we will share with you a subject we have chosen due to the increased demand on certain type of cases in our practice. I am talking about the congenitally missing maxillary lateral incisor. How do we work with spaces? How do we work with decision making, the biology, and the aesthetics? We have seen recently a higher expectancy in a patient missing a maxillary lateral incisor. Since this is an issue that brings together orthodontics, periodontics, and prosthodontics, the communication between colleagues becomes a key factor to the proper management of these type of cases.
Let's begin by defining what is dental agenesis. Dental agenesis is a congenitally absence of one or more teeth in the primary or secondary dentition. According to several authors, the maxillary lateral incisor is the second most common congenitally missing permanent tooth. The treatment of dental agenesis commonly comprises a combined treatment involving orthodontics, periodontics, and prosthodontics. Establishing optimal aesthetics, function, and periodontal health in this type of patients represent a complex and challenging process. As you can see, we are working not only with the periodontium, which we know is a complex area due to the space requirements in a lateral incisor, but we are also working with space issues and mechanics, dental inclinations, which will all affect the final outcome of a restoration.
Therefore, working with periodontal health, function, spaces, aesthetics, and timing should be adequately managed. With this in mind, let's go to the clinics. Imagine, we have Monday morning, you have a patient sitting in your chair after a long weekend in which your favorite football team lost. You're looking forward to change gears starting a new positive week. You have in the chair the daughter of one of your best friends from high school, a prominent lawyer, and she has a congenitally missing lateral incisor. So, what comes to your mind?
The two classical options that have been profoundly studied and discussed in the literature in the last years, which are Option A, open the spaces orthodontically and place either a fixed tooth supported restoration or an implant, or Option B, close the space orthodontically and do the canine substitution.
Remember, our responsibility as a dental care health provider is to study the case and offer the patient the best option according to her or his dental and life situation.
Hey Manolo, what do you mean by best?
Yes, Marcela, the best is personal. It applies individually for every patient. There is no universal best. There is an individual best which will depend on the characteristics of the occlusion, spaces, periodontium, etc. In some cases, we will go with canine substitution. Some others we will do tooth supported restoration, and some others we will do implants. All three options are great. It all depends on what the patient needs.
How do we determine what option to follow?
Well, for that question to be answered, we need to answer to ourselves some questions regarding the patient's records. The question number one is a key one. Is it a unilateral case or bilateral case? For me, as a periodontist, if it's unilateral, I must mimic the gingival tissue of the missing lateral incisor with the one in the contralateral side. But if it's bilateral, we will have to create a new free gingival margin for both new lateral incisors.
Orthodontically, if it's unilateral, it is common to tend to create another lateral incisor to mimic the one already present. As a note, when we have a unilateral missing incisor, it is also common to have a peg-shaped lateral on the opposite side. If it's bilateral, we will incline into the next questions we will mention ahead. This will help us make the decision. It is crucial that the orthodontist reviews with the patient the treatment options and take the proper decision for the case.
So, Marcela, why does the orthodontist take this decision?
Because these patients at this stage in life normally go to an orthodontic consultation. They do not have a periodontal problem and they're not going to go with the periodontist. That is why commonly we as orthodontists face with these decisions.
Interesting. And from a prosthetic view, when we have a unilateral congenitally missing maxillary incisor, the final crown has its complexity as well. It will have to mimic the one on the contralateral side. If the patient has a peg-shaped lateral incisor, it is very important to have both restorations performed at the same time. As you can see, the timing for both restorations also plays a key role in the treatment. On the other hand, when we have a bilateral scenario, prosthetically speaking, both restorations should adhere to the functional and aesthetic analysis. And this will lead to our second question.
Now, let's ask us the next question. That means, what type of occlusal relationship does the patient has? It is important to view the occlusion of the patient. As an orthodontist, if the patient has an angle class 1 molar relationship and a proper overjet without significant crowding, the decision upon opening or space closure will depend on the next questions. But in some cases, you might have a full cups class 2 molar relationship and excess of overjet, no crowding in the lower arch. If I want to correct the molar relationship and diminish the overjet, it takes several months to distalize a whole upper segment and achieve an angle class 1 molar relationship. In some occasions, you might think of leaving the class 2 molar relationship and close the spaces to decrease the overjet and end up with a class 1 canine. Of course, if the facial profile, that's our next question, allows. Another case might be an angle class 1 molar relationship with enough crowding to consider extractions. You can close spaces in the upper and extract in the lower. In some of these cases, it is not rare to think about space closure. Now, question number 3, that is facial profile. In any scenario, meaning opening or closing spaces, our aim is to finish with a pleasant and balanced profile. Some things we should consider are, if we are thinking on space closure, there's a high way if there is crowding and the amount of it. If there is not enough crowding, we know that by space closure, we will move the upper lip backwards. You wouldn't like to do that if it's a convex profile with retruded mandible and lack of pagonium. If it is important to think in any of these options what will happen to especially the upper lip, since it's the one which will be affected by any of both options. Let's go through question number 4, which is patient expectation. I have seen, based in my experience, some of my patient population prefer to work on the option of closing spaces and do canine substitution. The reason for this is that they do not want to struggle with spaces in the future. They want to avoid a long-term maintenance of a prosthetic replacement of the missing tooth, talking about implants or bridges in the future. What they ask me is if the profile of the patient doesn't get affected and if occlusally it's possible, try to close all spaces during orthodontic treatment. Economy also plays a role in this decision. Of course, as an orthodontist, I explain to them the pros and cons of both questions. Other patients as well are eager to work together with the future spaces and have a final restoration or an implant.
So finally, we go to question number 5, in order but not in importance. How confident our team is with both options? I think a key role to execute as a true leader is to have a team that is confident with the treatment options that we are offering. You have to believe in what you sell. Therefore, if we are offering the canine substitution option, we should have a very good restorative dentist that will execute a superb restoration that can look natural for the patient. This restorative dentist should dominate all the key factors in aesthetically compromised restorations, such as tooth shape, form, color, shade, emergence profile, among others. On the other hand, if we go for the opening space option, you must have in your team also a very good restorative dentist But now you also need a very good periodontist who can execute a perfect implant placement. Not to forget a very up-to-date orthodontist who can work on either option according to the latest literature and patient's expectation.
So now we talked about the 5 questions. Thinking about those questions, personally, I believe patient's expectation has a major weight in the decision making. The patient commonly looks for aesthetic and function. We should take our decision whether opening or closing the space based on the case characteristics we have mentioned in how we can transform the case and end up with both results. Some patients are driven from the past experiences or comments. Some are willing to comply with timing, others not. Some are not so critical in aesthetic factors, others are very critical in the aesthetic outcome.
This is where the team experience plays a key role. The team experience and philosophy will guide the patient towards the final decision. Now, we will share with you some cases where we decided to go with the open space option. In the future, we will present on part 2 of this lecture in which we will share with you some cases in which we work with the canine substitution. Let's start with the space opening for implant placement. Our first case is a case where we work opening spaces for a unilateral implant restoration. Remember, as our guide question number 1, in unilateral cases, it is common to decide open space for restoration due to the already present lateral incisor. So this is Roxanne. She was 19-year-old when I saw her, and she had just finished her orthodontic treatment. They decided to open the space, I believe for the reason mentioned earlier regarding the aesthetics and function. The orthodontist in charge of this case followed the guidelines published by Dr. Vince Koches in 1996, in which he proposes the canine to erupt in the lateral incisor area, after which they distalize it and place it in its final position. By doing this, an ideal alveolar ridge will be created in the space of the future lateral incisor, so as, when the implant is placed, no bone graft or soft tissue graft will be necessary. So when I see Roxanne after orthodontic therapy, I have an ideal mesiodistal and buccolingual space. Therefore, I can place an implant in an area where I have a very good osseous shield to have an implant and a mesiodistal osseous crest, so as to have a final restoration with an ideal emergence profile and papillas. This is a picture before the orthodontic therapy was carried out. You can see very nicely how the canine has erupted in the position of the lateral incisor. It will be now the time to start orthodontic treatment and move distally the canine. The original Seattle team had a superb article among many of them in 1997 in which they give the details on how to work ideally with the single tooth implants. In this paper, they explain in great detail some of the most important characteristics to take into consideration while working with single tooth implants. This is the view after the orthodontic therapy has finished. We can see an ideal space for implant placement with an ideal soft tissue and alveolar ridge. This was achieved thanks to the orthodontic therapy. So, in other words, the orthodontic therapy has not only achieved a great dental position for the canine and a stable occlusion and a wonderful aesthetic result, but it has as well achieved a superb regeneration of the alveolar ridge creation. This will allow us to plan an ideal implant placement.
Our next step now in the treatment is how to determine the ideal space for the missing lateral incisor.
The key to determine the ideal space for a missing lateral incisor is based on aesthetics and occlusion. From the aesthetic point, we will base our analysis in 3 points: the golden proportion, the diagnostic wax-up, and in unilateral cases, the measure of the contralateral incisor. Ideally, the maxillary lateral incisor should be about 2/3 the width of the central incisor. Most central incisors are between 8 and 10 millimeters wide. So if the central incisor, for example, has 9 millimeters in width, then the width of the lateral incisor should be 6 millimeters. If the central incisor, on the other hand, has 8 millimeters in width, then the lateral incisor should be 5.5 millimeters in width. So we can conclude that the ideal lateral incisor should have around 6 or 6.5 millimeters in width. If we have a lateral incisor with a width of 5.5, the case will be more complex to manage on the implant option. We will go deep in these points further in this lecture. On the occlusion, we will analyze basically the facial profile, the axial inclination, and the functional intercuspation. In some cases, we will do a Bolton analysis. This is the scenario clinically at the end of orthodontic therapy in our first patient today. She's ready to start with the periodontal implant evaluation. Our first question is the age of the patient to determine if she was already in a safe age to consider implant placement. She was at that moment 19, which in a girl is almost always a safe age to go and place implants. Now, we normally, in this issue of the age and implant placement analysis, we normally evaluate the patient evolution with her foot size. We also evaluate 2 cephalometric analyses with 6 months in difference. And when there is no difference between the 2 cephalometric analyses, we can be pretty sure that we are on a safe side to consider an implant placement. So, at what age should we place implants?
There is some literature, a lot of literature actually, that talked about this age. One of the articles published by Hodge and al. In the JOMI issue of 2006, in which they gave out all the factors that should be considered in facial development, continuous tooth eruption and mesial drift, for an ideal analysis of either taking the option of implant placement or going for a fixed tooth support restoration. So, what we can do to determine if the patient has an ideal age to place implants, we should consider the following. First, take 2 lateral cepts within 6 months interval, or it can be within 1 year also interval difference, and measure if there is any difference between both. Have a constant communication with the patient and wait until the patient experiences no growth differences within 1 year time. Evaluate body growth per year and see if it is not above 0.5 centimeters per year. Evaluate also changes in dental position within the dental arch, such as eruption of the second molar. We think that if our patient is above 18 years of age and follows any of the previously explained parameters, we will be on the safe side to offer the implant option of treatment. This is in order to avoid a future peak of growth that could change profoundly our implant restoration, and the aesthetics of the patient will be drastically severed.
So we have the ideal space on an ideal patient with the ideal age to consider the implant placement. A diagnostic wax-up was made by the restorative dentist, so we can evaluate where we can take the dental treatment of our patient and discuss the details with her. It is very important at this stage in treatment to have a patient not only satisfied with the proposed treatment, but as well convinced that this is the best treatment for her. We usually try to involve our patients with the treatment, give them enough information so as to motivate them with the treatment as we advance. The implant option is taken and the patient is programmed for surgery. On the surgery, on those days, I open a full thickness flap, trying to be very conservative with it and not only open the missing lateral incisal space and half a tooth on each side, in such a way that the flap can be raised and I can have a very nice and ideal view of the alveolar ridge in which we can certainly place an implant, expecting to have a good bone shield surrounding the implant. The implant is placed following a surgical guide performed by the restorative dentist. The surgical guide for this case is very important because it will give us the ideal angulation, inclination, and position of the implant. On the maxillary anterior implant, these 3 points are very critical: the inclination, the angulation, and the depth of the implant. The surgical guide is open in the center of the missing lateral incisor, but it remains the cervical copy of the future restoration in an acrylic from the diagnostic wax-up. This is a critical point because it will help us determine the correct implant depth. The implant we decide to work with at that moment was a novel replace implant, mainly due to the diverse prosthetic options they offer. The implant was placed exactly on the center of the dental space, following all the guidelines of the surgical guide. We can see that the implant has a sufficient amount of bone as to the mesial as well as to the distal, so as to have a nice osseous crest with the future papilla that will be formed on this restoration. It is also very clear that implant has a buccal bone crest that will assure stability on the soft tissue surrounding the implant in the future. And this is the final restoration, 6 months after the implant was placed. I think the result is very nice, aesthetically, biologically, and functionally. And we all know that this has all the possibilities to stay as it is for a long period of time if properly taken care of. Nowadays, certainly we can achieve a similar result with less surgical protocol or a less invasive surgical approach, and an immediate restoration could be also managed nowadays. We can see the sequential pictures of the advancement of treatment, which ends with a nice implant restoration to substitute the absence of tooth number 7 or 1.2 on the Universal Numerical Dental Classification. Now, at this point, it is important to emphasize some concepts that we consider critical in the management of single implant placement for the absence of maxillary lateral incisor. The first issue is how much space is ideal. In the majority of the cases, the orthodontic treatment will end with a space of around 6 mm mesiodistally. Sometimes it will be less, sometimes it will be more. We have discussed previously today how to determine the ideal space for a missing lateral incisor based on the characteristics of the occlusion and the aesthetics of the case. Now, from the implant point of view, the minimum ideal space will be 6 millimeters. Why 6? Because, well, if we have less than 6, we will be very tight for an implant to be placed with all the characteristics that will allow the implant to have a success aesthetically, functionally, and biologically. We should keep in mind the 6 mm of space should be maintained crestally as well as apically. In other words, there should be a root parallelism between the neighboring teeth. This is a very critical point to consider. If we go deep in this point, we can start analyzing the different implant diameters available in the market. The narrowest implant we can utilize is a 3 mm in diameter. So if we have 6 millimeters in space, mesiodistally, and we place an implant of 3 millimeters in diameter exactly in the center of the available space, we will end up with 1.5 millimeters of bone crest on the mesial and on the distal of this implant.
In some cases, orthodontically, it is hard to open a space 6 millimeters between the teeth. This might be due to a bolt-on discrepancy. In some cases, we should think thoroughly before taking the decision of what options we have to restore it.
Dr. Salama, Garver, and Adar in 1998 published a unique paper in which they very nicely explain the importance of having at least a bone space of 1.5 millimeters from the implant margin to the neighbor tooth, mesial and distal from the implant. If we add 1.5 on the mesial and 1.5 of the distal, we will end up with 3 millimeters. And we can now add 3 millimeters of the diameter of the implant. This will give us a total of 6 millimeters. So if the space available for implant placement is 6 millimeters, we are in a correct but a difficult highway. What happens if that day we don't have the guts of implantology on our sides at the time of surgery? We should finish out placing the implant on the exact prosthetic point to have a total success. But we must keep in mind we have no margin for mistake. This is, in my mind, is like going down to a bullfight arena and getting the cape to confront a bull. We are playing with fire and we should understand the consequences. That is why, as a periodontist, we always try to push or ask for a broader space. There are a lot of times an orthodontist will determine the space based on the sequence of the case and even sometimes remove the brackets before the periodontist or the implantologist reviews clinically the case. We think a good communication between the specialists will benefit tremendously. A clinical examination appointment with the periodontist before the orthodontic brackets removal is very critical in the complete management of the case. Once we have the ideal space, we should understand what characteristics are also important to follow in order to have an implant success. Remember, this table from Salama and Garber's paper is just the perfect piece of information you should never forget. I personally follow these tables such that I have a copy on the surgical suite of my office as well as in the lab so that everybody in our team not only knows but understands why we should respect certain spaces with each implant we place. I think this paper made a critical drift in the understanding of the connection between biology, aesthetics, and function. Classic in my understanding of implants. From the characteristics of the implant placement, our next critical factor to consider is implant depth. We must keep in mind that the tooth we're working with, if the lateral incisor is the tooth to create, the implant should be placed around 2 mm apical from the cervical crown of the new crown to be placed. How will we know this in advance? How we will know this before the surgery? Well, with the diagnostic wax-up. A good planning of the case with an ideal diagnostic wax-up, perfectly planned between the prosthodontics, the orthodontics, and the periodontics, will give us the ideal implant crown cervical margin prior to the surgery. Once we have this on the wax-up, we will translate this information to the surgical guide. This will allow the periodontist or the implantologist to place surgically the implant exactly where the prosthetic needs of the case demand. So to summarize, the implant crest margin should be 2 to 3 millimeters apically from the cervical margin of the future crown to be placed. Now, another point which is important to consider is the buccal-palatal implant position. The buccal-palatal implant position is a critical point. Nowadays, we have understood, based on many studies, that for a maxillary anterior implant placement, we should aim for a position more towards the palatal. If we could be in the palatal aspect of the cingulum of the tooth to replace, that would be ideal. Why? Mainly because by doing such, we will have a good and thick buccal alveolar bone. And this is very, very important. We should have around 2 millimeters of buccal alveolar bone so that we can have an stability of the soft tissue surrounding the implant in the future. So an implant placed in the palatal area of the cingulum will have an ideal placement to create a nice buccal bone. The last in order but not in importance is implant angulation. The implant angulation should have a emergence profile that should be created from the incisal edge to the cingulum. Now, we will go now to our second case in today's lecture. The second case of the day is a similar case in the issue of the missing lateral incisor, but the management ended up with a different result. It is important to analyze the differences and try to get a closer in our daily journey to better understand the language of the tissues.
Okay, this is Marco. He came to my office looking for an orthodontic treatment. His chief complaint was closing the spaces between his upper incisors due to peer pressure. This was a big issue in his life at that moment. Upon evaluating his facial profile, we can see he has a convex profile with a lack of pagonium and over-eruption of maxillary anterior teeth. As you can see, he has a missing maxillary lateral incisor and still in mixed dentition. He has a deep overbite due to over-eruption of the maxillary incisors. His upper midline has deviated to his left side and has an excess of overjet. He is a class 1 angle molar relationship. When we see his panoramic X-ray, we can confirm he is congenitally missing his upper left lateral incisor. Please notice the osseous relationship with the central incisors. The osseous crest is located apically to what we normally see on a patient at this stage of growth. If you go back to the facial photograph, you can see the crown length of his upper incisors. It is longer than usual, somehow greater than a central incisor crown length at this age. In the lateral Ceph X-ray, we can see a mild retruded mandible. We started a phase 1 orthodontic treatment due to his chief complaint. He started a 2x4 to close the spaces of upper incisors. You can see the spaces are closed, the midlines are corrected. Once the midlines were corrected, we let him rest for a couple of years and wait for growth. He used actually also hypal headgear to help something with his mandibular growth. There is an important point to consider in this case at this moment. Patient had a difficult time at school due to his mild appearance. They asked me to place a provisional restoration at the place of the missing lateral incisor. As we mentioned earlier, according to the article by Dr. Skokich and his group in 1996, it is ideal to let the canine erupt in the position of the missing lateral incisor. For the reasons mentioned earlier, this approach, we couldn't make it because of the reasons I told you, peer pressure. Okay, so we let him rest for a couple of years. Couple of years later, he came to start his second phase. You can see brackets were placed, initial leveling and alignment. And now we're preparing the space for the future lateral incisor. We can see his facial appearance and smile. As you can see here, we are settling the occlusion, an angle class 1 molar and canine relationship, but notice something that still makes noise in my head. Look at the crown length of his upper central incisors. He's 14 years old now.
Retrospectively, looking at the pictures, pay special attention to the ridge on the missing tooth number 10. Later in today's presentation, we will go deep in this matter.
This is the occlusal view. In the panoramic, we can see spaces are ready for lateral incisors. The roots are parallel in order to leave space for a future implant or restoration in case he decides to take the implant option. He is now ready for debonding. One thing I've noticed in these cases is the importance of having a good contact point between the provisional crown of the missing tooth and its neighbors. Since the canine is a tooth with a conical root, it is easy to rotate during the retention years before its final crown. We can see here the final facial profile. Debonding. In this case, Marco asked to have something fixed as a provisional restoration. We talked about what options he had for the missing tooth. We discussed with him the placement of an implant or a fixed tooth restoration. He and his parents decided to go for the implant option, but due to his age, as previously mentioned, he was not ready for an implant at that moment. Notice, he is a boy. Boys grow more than girls, more later than girls. We would have to wait some years for this procedure. What can we offer him at this moment? He had the option of using a removable holly with a pontic or having a fixed tooth bonded restoration. He preferred something bonded. This is a fixed tooth bonded restoration, and this is how he finished the active orthodontic treatment.
So Marco comes to see me 6 years later. He is now 20 years old. At this moment, in some cases, it is a good time to go for the implant placement. But some of the cases have their last peak of growth at this stage. So to be 100% sure of his growth stage, we will take 2 cephalometric x-rays within 6 months of difference in time, so we can confirm there is no more significant face growth. Remember what I told you earlier. Pay attention to the image of the edentulous ridge at the time when the orthodontic treatment was finished and compare it to the image as it is 6 years later. What happened? We don't know. But for some reason, there has been a resortive pattern in the ridge. One hypothesis is that on the pattern of eruption of the canine, the canine never touched the central incisor. Now, if we want to follow strictly what Dr. Kokic's advice had on his paper and his research of the canine erupting into the place of the missing lateral incisor, we can see that this did not happen strictly as it was detailed. Could this play a role? We don't know, but we feel this might be something important to mention. This is a sequence of x-rays. Let's observe and talk about the sequence of x-rays.
This is how Marco started, you can see, and this is how Marco was towards the end of the second phase of treatment. See how the canine is erupting? It never touched the lateral. And that's when the provisional was placed on him. Before second phase, now during the second phase treatment.
And this is how he comes now to my office. So now we have a class 1 defect according to the Sievert classification. And what options do we have? What can we do? We know we don't have the ideal scenario for an implant to be placed. So what can we do to have Marco in the ideal scenario? I think what we can do is certainly 3 options of treatment. The first one is we can do a guided bone regeneration by itself, per se. We can do a guided bone regeneration with implant placement, or we can just go for the option of the tooth supported restoration. If we go for the guided bone regeneration, we should do the guided bone regeneration and then we should wait 6 months of healing and then have the implant placement with PRF and a connective tissue graft. And afterwards, we can have the implant restoration after the implant has healed completely. I think this will be the way to go with Marco. So, after today's presentation, within the limits of our experience, we have created a summary of today's presentation. We can conclude the following.
When you face a patient with a congenitally missing incisor and you have to decide between opening or closing spaces, think about this. There is no single best option. The ideal treatment will always be what is best for the patient individually, based on his occlusion, spaces, and aesthetic needs.
These type of cases always require a team approach of the dental work management.
Think about 5 questions you might ask to yourself that may help taking the decision. Question number 1, is it unilateral or bilateral? Question number 2, what type of occlusion does the patient has? Question number 3, facial profile. Question number 4, look at the patient expectations. And last one but not least, what is your team approach? Some points we should never miss. If we are planning to open a space for a future implant, we should remember, orthodontically, to have a minimum of 6 millimeters mesiodistal space for an implant to be considered. Number 2, it is crucial to have parallel root angulation between the neighbor teeth. Number 3, the contact points should be considered before debonding. Contact points between lateral incisors and canines, since it is crucial to maintain alignment during a large growth period. A very buccal contact point will induce a future gingival recession.
Now, from a periodontal point of view, the final remarks, or the most important points within the limits of our experience will be that the implant should be placed 3 millimeters apically from the free gingival margin of the future implant crown. A buccal bone wall of 2 millimeters should be present surrounding the implant. This is a very critical point, especially in the maintenance of the soft tissue on a long term. And the implant should be placed towards the cingulum area. In other words, more towards the palatal than to the buccal, in order to have the 2 millimeters of thickness of the buccal bone. Of course, these aside of the angulation of the implant and the position of the implant following the surgical guide. I think that if we deliver our surgical work in such characteristics, the possibilities of having a future implant with all the parameters of having a very good aesthetic, biological, and function result will be extremely high. And this is the key in order to have a good success in our treatment. When we are able to combine the science with the art and do that predictably, then we will be happy that we are delivering the type of dentistry that we will all want to have. We would like to thank you for your time, and we hope to see you soon on part 2 of this series. We are from Monterrey. This is a view of Monterrey. This is a city in the north of Mexico surrounded by mountains, and this is the view we get on the airplane when we're coming back. Part of the city covered by the clouds and the mountains waving hello in case one of you guys would like to visit us in the future. Thank you, Dental XP, for the invitation, and we hope to see you soon. Bye-bye.